I am extremely happy to offer everyone a warm welcome to the inaugural annual conference for the Society for Digital Mental Health. We have over 400 registrants, which is, I think, far more than we expected, but also a sign of just how far digital mental health has come as a field, and I think is also a viable treatment. We all, I think, in this meeting share an understanding of why digital mental health is important. We have a broken mental health care system. 25% of Americans will have a diagnosable mental health problem in any given year. 50% of them receive no treatment whatsoever. And of those who receive treatment, a lot of that is suboptimal. And we've just gone through, or hopefully just gone through, a pandemic that has highlighted the importance of mental health and also opened the doors to remote treatment in our healthcare system. But capacity problems remain. We will never have enough mental health clinicians to serve everybody. And clearly the time for digital mental health has come. And that's really the mission of the Digital Mental Health Society, to advance and improve digital mental health care. I want to start off here by thanking the Bowman Family Foundation, Brain Futures, and the Massachusetts General Hospital Center for Digital Mental Health, who have supported the society and are supporting this meeting. I also want to give a shout out to our board members, in particular Bethany Teachman, who is our program chair and has worked tirelessly to put this together, Stephen Schuler, Zabina Wilhelm, and Adam Powell, and a special shout out to Emma Wolf, Sarah Hill, and Jeremy Eberle, who have helped us figure out how to use this Zoom platform. So I'm going to talk a little bit about how the society came into being, and then a little bit about this meeting. So you can kind of trace the origins of this society back to October 2019, when the Banbury Center sponsored us to have a meeting. The Banbury Center is a conference center out of the Cold Springs Harbor Laboratories. They sponsored us to have a meeting to look at why there's a research to practice gap in digital mental health. And in particular, kind of what the barriers are to rolling out digital mental health care in the American digital mental health in the American healthcare system. So we brought together stakeholders from healthcare organizations, insurance and companies and payers, self-insured employers, patients, researchers, and met for several days and came up with a consensus document that was published in Psychiatric Services in January of 2021. And there were three consensus statements. The first is that there is a tremendous opportunity here. There was overwhelming consensus that digital mental health interventions provide effective and scalable methods of extending reach, particularly for common mental health problems like depression, anxiety, and PTSD. And those are most notably effective when there's some human support, some low-intensity coaching on the back end. They also identified two challenges that are critical to rolling out digital mental health. One is the importance of having reimbursement mechanisms. So there are a lot of healthcare organizations like Kaiser and the VA that operate outside of the fee-for-service model, but most Americans are served by healthcare organizations that operate with a mix of payment models. So without having a reimbursement structure, it is not going to be feasible to deliver digital mental health care to most Americans. And the second was assistance to decision makers in how to select those digital mental health products and services that are going to be most effective. And so the recommendation was to create a digital mental health therapy evidence standards framework. So with this in hand, then we met with a number of groups, including Brain Futures, which was instrumental in establishing the behavioral health codes. We met with representatives from the American Medical Association, experts in mental health care financing. And a critical piece that was identified in order to move forward this policy was having a professional organization that could support policy. And we looked around and saw that there are professional organizations for digital health and there are professional organizations for mental health, but nothing at that intersection. And so we saw that there's both for the policy as well as for the field, this was an important gap. And so, that led to us founding this organization. And the aims of the Society for Digital Mental Health are first and foremost to be a big tent organization. So not only researchers, but also to include people from, insurance, pardon me, industry, policy experts. We need to be a big tent organization in order to address the problems confronting digital mental health. The organization will support education, policy, research in the use of digital tools and services to improve both mental health and substance use disorders. We aim to help assist in sharing information both within and across these different groups. And then importantly, we want to ensure that digital mental health also addresses the needs of those communities that have those underserved communities that have not been served by our current mental health care system. So the meeting today is essentially an outgrowth of that. And so the focus of this meeting today and tomorrow is on implementation, and in particular, potential routes towards reimbursement mechanisms and how we can ensure quality in digital mental health through evidence standards. We have two keynote speakers. Today, you'll be hearing from Tanzeem Choudhury, who I will introduce in just a moment. And then tomorrow, you'll hear from David Clark. And David Clark was instrumental in establishing the current programs for delivering mental health care within the English national healthcare system. And they have begun to roll out digital mental health within that care system. And so I think we have a lot to learn from those countries that have gone before us. There are also two panels. Those panels, we'll have speakers from a variety of areas: mental health care financing, payers, academics, policy, industry. And the first one today will be on evaluation standards for digital mental health therapies. And then tomorrow will be on potential reimbursement mechanisms. We have flash talks and poster sessions, and the poster sessions are almost like mini talks in this format. Those will be held in breakout rooms. And then importantly, after the panels, we're going to have breakout groups to discuss what was presented within the panels. And this is, I really encourage you to join. Each of these breakout rooms will be staffed with a moderator who's going to be taking notes. And this is an opportunity for you to tell us your views and to become involved. At the end of the talk, at the end of the meeting, I'll also talk a little bit about how you can become more involved in the society, and we'll be sending out information about that. And for those of you who have not yet joined, please, I encourage you to join. It's free to join the society. Finally, before we get started, I want to beg some patience and indulgence. We had originally wanted to have this meeting in person, and when we started to plan it early this year, that was right in the middle of the Omicron surge, and we didn't feel comfortable as a small organization taking the risk of putting together an in-person meeting that we might have to pull back. So we did do this year remotely, but I hope in the future that we'll be able to have a meeting that is, next year, a in-person meeting where we can get to know each other better. Also, we're doing this over Zoom. We're a small organization running on a shoestring. No company is running this. It's just a few of us who haven't done this before, and we're doing our best to serve as AV and tech support. But if there are glitches, I really beg your indulgence in advance. So with that, let's get started. And I want to introduce Tanzeem Choudhury. So Tanzeem is somebody I've known for many, many years, and she is really an extraordinary individual. So many of us, are either really good at depth or breadth. We either take a subject and we dive deep into it and become the expert in that area, or we're good at breadth and are able to pull things from lots of different areas and create something new. Tanzeem is one of those rare people who has done both. She has, mastered a number of different areas and gone into depth. Really, so one of the few people I know who's been able to do that. Tanzeem is currently a professor of computing and information sciences at Cornell Tech. She is also senior vice president for digital health at Optum Labs, and is also the co-founder of a digital mental health company, Health Rhythms. Tanzeem is truly a Renaissance woman. So I'm really pleased to introduce her to you. And as she's speaking, please go ahead and put in questions you have into the Q&A at the bottom of your screen, and we'll get to as many questions as we can at the end of her talk. Tanzeem, it's a pleasure.
Thank you, David, and thank you for the extremely generous introduction. It's an honor to be here, and kind of your thinking and expertise has influenced me over many, many years. So a lot of what I've done has been influenced also by many, many conversations with you as well. So I'm going to get started, and let's see. Here's so what I don't see now is if people are seeing full screen of my talk, and I guess this is one of the glitches. I usually see my version of my talk, and I don't see it now. So can someone tell me if you're seeing my slides and if it's full screen? Let's see. Okay, we can't see the slides. Okay, this might be the first kind of technical glitch. We tested it. Let's see. Let's try this again. All right. I think you can see my slides now. Is that right? Yep, great. Thank you. All right, so it's a pleasure to be here with all of you. And as David had mentioned, that this annual meeting is about digital mental health in practice. And I wanted to kind of share, in some ways, my journey and kind of steps that I've and my group and the large number of people I've worked with took in creating a unified digital mental health product that touches both patients and providers. And it's been a journey that also kind of started with research and included a startup, and now working with within a big payer organization in the US. And just, I hope some of what I can share is the trajectory and what were some of the important kind of lessons learned along the way that helped shape kind of my thinking and resulting product that I've been involved in building within Optum. So one of the things that from my research, and I come from a computer science, electrical engineering background, was started with measurement, right? When I've been working in the space of kind of mobile devices and mobile sensors for many, many years. And one of the things that it enables us to do is continuous measurement. And that is something that's been challenging to do in the realm of mental health. So if we look at kind of our existing state of the art, it requires a lot of input from the patient, involvement of the clinician in trying to assess symptoms of mental health, right? But if we kind of delve into it, and this is the PHQ-9, which is used for depression, there is aspects of measurement that we can now capture continuously from the devices that we carry. If we look at our sleep, energy level, kind of activities that we engage in, as well as kind of psychomotor activities. And in some of our work, we've seen that come across in also the patients that we worked with, right? So if there is aspects of our sleep, our timing of sleep, interruptions of sleep, ability, kind of shrinking of our social circle, which may be represented by changes in our mobility patterns, even just the way we walk and talk. So there are quotes about just my legs bounce or speech goes fast. My wife can tell by my walk. It is looking at more of the nuances of how some of these things change, right? The pace slowing down or speeding up. And those are some of the things that are harder to often self-report on. But that we are now able to get these signals continuously using just the smartphone we carry, right? So we now half the world has some form of smartphones, and they allow us to start getting at these symptoms that are really instrumental in understanding kind of state of someone's mental health, and also capturing improvement or decline. And over the years, other devices that were more cumbersome or harder to use or very niche is becoming more and more widespread. So the smart watches are being more widely used. We have things like the wearable jewelry, Oura Ring, something that I've been continuously kind of using myself for about 3 years, and also smart speaker and other connected devices that can give us a lot of information about some behavioral symptoms, right? So now one of the things that in terms of when it comes to implementation that I learned as soon as I started working with clinical practitioners and clinical researchers is that just getting these symptom level data and is not enough, right? Most of the time, if you're in a clinical practice setting, you don't have the bandwidth or the ability to interpret all the signals to enable clinical decision making. So what is really, really important is to take all these continuous measurement and generate prediction that is actionable and clinically useful. And that doesn't overwhelm the clinician with too much data where there is already a shortage of their time and a lot of clinical, they're struggling with burnout and which is really even amplified during COVID. So that kind of led us to think about how do we take all this data and generate prediction that can be actionable, and it is really in some ways really highlighting key pieces of information rather than giving too much information. So one of the things that we focused on is, can we actually start predicting a psychiatric event, and how do we do that in a way that is really both generalizable, can work across people, but doesn't require a lot of person-specific effort in terms of training these models. And one thing that we worked on is what happens and when we go back to the clinical kind of assessments, the PR or the PHQ, which I showed, is all about someone's change from the baseline, right? So has your sleep pattern changed? Has your how you are eating, talking, moving around is changing? So one of the key things was to look at how do these behavioral symptoms that we can now capture changing over time, and is this change persistent over some period of time, and are we seeing these changes across multiple symptoms? And that's kind of then if we can look at that, is this predictive of a change in a psychiatric episode? So that's something that we worked on, is can we actually look at changes in these symptoms over time across multiple domains to predict early on a psychiatric episode. And we did that in the context of schizophrenia and looking at it more broader. What we saw that if we now look at these behavioral anomalies in term was from a machine learning language and anomaly detection, but now looking at these anomalies over time across multiple symptoms. So the more anomalies across dimensions that we see and that persist over time, the more predictive it is of a change. In this case, we were looking at psychiatric relapse, and in the bottom right graph, you can kind of see that someone's anomaly rate, that means the number of dimensions their behavior is changing, and the intensity of it is rising. So this is one way where we can actually digest and condense this information to kind of reveal something that is clinically actionable without requiring in the clinical practice, the clinician or the care team to have to go through a lot of information and digest that. So the next is that, okay, if we can get at this anomaly, how can we use it in a clinical context? And so the intervention and how intervention is done becomes important. So one of the things that we did in the context that I talked about before was to collect this continuous data and generate some level of a symptom severity score that then can alert the clinician if it exceeds a certain level. And then the clinical care team can decide whether directly to reach out to the patient or alert the physician that may have the most limited amount of time, and whether they need to meet directly with the physician. So this was also got us to think about how some of these signals and data could be embedded in a clinical kind of setting, clinical practice. One of the things that we learned, and a lot of this work was done in the context of research and clinical research, where the barrier that we were able to cross there is the barrier between sometimes technology-centered research and clinical research, where we really advance both kind of clinical research as well as the technology. Like, this was the first time we were collecting a lot of a year's worth of data using mobile devices with serious mental illness patients. So this was kind of allowed us to really kind of work hand in hand to advance both fields. And that kind of led, that has really influenced my thinking and some of the work that I continue to do with my colleagues and collaborators is, how do we kind of think about digital mental health evolving? And if we kind of look at it, there is a lot of technology advances, but one of the things that we have to think about is not only the clinical advances, but clinical integration. And even in the research context and kind of continuing forward, what was really important is not just kind of developing the technology and handing it over for clinical integration, but really seamlessly going back and forth and integrating and making connections between the two. And I think this has been hugely important. And I think it's hugely important in really making digital mental health solutions scale in practice and be adopted in a way that doesn't create additional burden in terms of how to consume this information. And then this, as the kind of research work evolved, that kind of led to, as David mentioned, in terms of thinking about implementation and how in practice, which is something that I've been involved in kind of co-founding a startup called Health Rhythms, which with my close collaborator and colleague, Mark Matthews, as well as clinical collaborations that we had with Ellen Frank, to kind of think about how do we take some of these digital mental health solutions and really kind of productize it in a way that is really easily can be integrated into clinical care practice. And one of the ways that we did that was allow this kind of measurement, the digital signal-based measurement, to be very easy and seamless, that can work cross-platform, that not only is required to be a standalone app, but can be integrated into an SDK and do some real-time objective kind of analysis to do predictive analysis of changes in behavioral health. But as David kind of mentioned, what was really crucial was thinking about how does it fit into a broader ecosystem, right? And I think if we think about digital signals per se, digital mental health solutions, they, after all these years, kind of my kind of how I would think about it is it's a part of a solution and it's not the whole solution itself, right? Digital data and measurement is extremely valuable, but so is the data from the clinician's note who is looking at the patient. Also is the record of their prescriptions and electronic health record. So I think in order to really truly kind of scale digital mental health solution, we have to kind of think about how does these approaches really fit into the whole ecosystem of care and delivery of care, which is what kind of led me to being involved at Optum and Optum Labs, where I really was interested in thinking about, and what David mentioned, like there is the payment models and payment incentives. What are some of the bottlenecks, and how do we kind of think about embedding digital mental health within the bigger system of data and care delivery? So I joined Optum Labs just kind of about like 16 months ago, like just when COVID was really in the forefront of everyone's kind of mind, but also it within kind of Optum's and other care, like health systems and healthcare were becoming more and more aware of the behavioral health kind of pandemic, right? So and thinking about when it's more seriously thinking about the need to integrate behavioral and physical health care, so the integrated care model, and also looking at the overall benefit and how can we support that in not just as a kind of behavioral health care within just one's therapist and psychiatrist, but actually embedded in also a primary care where we can integrate the care delivery. And this kind of overall picture shows that, as David mentioned, a lot of people have behavioral health concerns, and now I think during the pandemic, it's about 1 in 3 have some kind of behavioral health concerns. The other thing that really is important for chronic kind of integrated care is that 1 in 3 patients with chronic illness have behavioral health, and it really has an impact on the cost. And if we look at the graph at the right, it shows that like behavioral health with chronic disease really actually increases cost to 5,000 to 8,000. And even in this case, the graph is for type 2 diabetes. Even for asymptomatic depression, you can see an increase in cost. And the other thing is that most of the kind of depression and anxiety is managed by primary care physicians, and about 80% of antidepressant prescriptions are done within the PCP. So there is growing interest, and even if you look at like United Health Group CEO, in its talks about integrated behavioral health care and how do we really scale that. And one of the most clinically validated models, and I think you'll hear from Pat Arian at the University of Washington either today or tomorrow, like was the collaborative care model that originated within University of Washington, is to kind of, which is a model which has been most backed by kind of clinical clinical trials that shows that if within a primary care, the patient is at the center of the kind of triangle, primary care physician is doing most of the interaction with the patient, but has a behavioral health team that includes a psychiatric consultant that is communicating most with the primary care, the behavioral health clinician, and then there is a psychiatric consultant who is a psychiatrist who can come in for when there is a complicated case or thinking about medication that might also interact with other medication that the patient is on. And this has shown to be, and this is embedded in the clinical care practice, which has shown that people tend to seek out behavioral health care more. There is also kind of the notion of being a unified care team with a primary care office reduces some of the stigma. And overall, there has been a significant improvement in patients' depression and behavioral health concerns. But some of the challenges of this collaborative care model within a specific type of behavioral health, integrated behavioral health, has been that often the primary care physician still lacks the training and support to scale this model. There is serious clinical shortage that in order to, unless there is some kind of digital mental health or technology enablement, it's very resource intensive. There's also a reimbursement model, which is, there is a COCM code for reimbursement, but there is, in order to accounting for timing and all those, also is complicated. So, and then tools for measurements can be subjective and intensive. So this is a really interesting model, an area where I think digital mental health solutions can really make a big difference, because without that, it's not gonna scale. And so what we need is to actually not only help the patient, but help the physician find the best path for behavioral health care more, and also understand how both the treatment, pharmacological and other kind of therapy and intervention, how should it be integrated, and overall support in more effective integrated care. And this is what the work that I've been involved in at Optum, and actually with close collaboration and partnership with Dr. Cecilia Livesey, who is a psychiatrist who started the collaborative care model-based integrated health program at Penn Medicine. So, which allowed us, the other thing was really important in kind of thinking about behavioral health in practice, is the ability to work with experts like David Mohr, and I've had close collaboration with John Kane at Northwestern, but also clinical practitioners who have actually stood up systems and have thought about technology integration. So what we are trying to build towards at Optum is what we are still calling, it's called Project Loop, where the goal is to kind of think about how digital tools and digital signals and digital therapeutics can fit into the whole ecosystem. And particularly, we are focusing on integrated behavioral health, but it can ultimately scale to other models as well. And one of the things that is important is that although digital sensors and signals-based data is predictive, but really to make everything work together, we can't just rely on that, right? So we have to kind of bring together traditional healthcare data, and we need to create this a platform that generates digestible information to the behavioral health team and the primary care physician, and also for the patients that are suffering, to give really precise, relevant intervention and create that connection with the physician. And one of the things that, in my opinion, digital mental health suffered is there are some great solutions that are related to measurement. There are great solutions that are on the digital therapeutic, and that is self-directed care, and also kind of virtual care in terms of, let's say, virtual cognitive behavioral therapy. There are some tools on the behavioral health and clinical side to do some amount of clinical decision support and some amount of support with billing and billing integration. But these things need to come together. These things need to, information needs to flow together. Otherwise, we create a fragmented system for digital mental health care that is sometimes fraying the therapeutic alliance between the patient and the behavioral health team, and also is not creating this, leveraging the trust and the bond that the physician and the patient might have. So this is what we are trying to aim at. And the other thing is realization. There's really great depth and body of research in each of these areas in terms of measurement and digital therapeutics and clinical decision support and these types of models. But these are often siloed, and one of the things that we are trying to do is bring experts and best-in-class solution and actually create a platform that connects everything together. Instead of 5 different applications or 5 different apps, the patient has a unified a front end where we deliver measurement as well as intervention. It is kind of in the back end in the Optum's health cloud. It is combining it with traditional healthcare data and novel signals to generate insights that is being presented to the behavioral health EHRs that exist and being used in a integrated behavioral health context, and as well as integrated into the traditional EHR in the right way, in the right workflow of the primary care physicians. So initially, the solution is focusing on automating somewhat with the kind of course, connection with the physician and care team, but the information flow is fully automated, and we are leveraging the existing kind of integration between the behavioral EHR and the existing EHR that the PCP is using, and ultimately that connection and flow is going to be there, and with the goal of really thinking about that. This, once the clinician is prescribing an intervention, it flows back to the patient. The idea is that it's going to be this continuous flow of information, but something that the physician or the care team is only digesting when it's needed. But it can be adaptive, personalized, and continuous. And kind of our hypothesis for this is that we really are going to create a coherent patient experience that actually leverages the therapeutic alliance between the patient and the provider. We are really combining signals that on its own may create a piece of the picture of where the patient is and have a more unified and robust picture of the patient, because no signal is going to be super accurate all of the time, but we can now combine the strength of all of those signals and make a reliable assessment over time, and then deliver the kind of clinical decision support that allows us surfaces the patient information at the right time and allows us the physician and the care team to take the right action, and it's integrated with other relevant health data, so that the action that is taken is taking the holistic state of the patient. So there, I'm going to just kind of walk you through the journey overall, right? Here also, in order to leverage this trust and alliance between the physician, and often it's seen in practice that if the physician is recommending the patient to use something, they use it more and continue to use it as well. They will actually engage with it initially and continue to use it. So our model is where in a primary care setting, the care team is recommending the use of this app, which is a unified application that is looking at digital signals, patient-reported outcome. There's also a conversational agent that is built, has shown some clinical evidence in creating therapeutic alliance. And then this data is going into the back end and being combined with the traditional healthcare data. And all this data is combined to look at what is the next best step for care, and this can be also reviewed by the care team to provide the recommended intervention. And here again, this unified experience is important. Someone who has mild to moderate depression may be referred to some self-directed care, which reduces the kind of burden on the physical clinical team to deliver care, which is, we know there is often a lot of these clinics have waiting lists and a backlog. But for serious patients, they might focus their resources and in-person time to bring and work with the patient. So it allows us to kind of dynamically adapt of using the different therapeutic intervention in the right way. And then if there is a self-directed intervention, it's delivered within the same application, and it can be prescribed from the care team. Again, that also helps with the patient having trust in using that and knowing that their physician is leveraging that data in delivering care, so it can improve the engagement. So overall, we are trying to kind of build a next generation digital care model for really that could potentially be scaled and fit into existing clinical care model, which expands on the data with combining the traditional data with passive data. It is really trying to create predictive models that can help clinicians make the right action and deliver the right intervention so that we best utilize the clinician's time and also take advantage of the relationship and alliance between the patient and the clinician. And of course, all of that, the data and the kind of algorithms underpin all of our vision. And our goal is that just like in mental health treatment, we see that stepped kind of care has been successful. What we want to enable is stepped measurement and stepped engagement to deliver that stepped care and clinical decision support. And one of the things that we will be looking at is in terms of outcomes, how are we improving in terms of predictive ability, our clinical outcomes, the engagement, of course, the cost, and how do we enable kind of reimbursement of a solution like this. So with that, I'm going to end here. Thank you for your time, and we have some questions. Happy to take them.
Thank you, Tanzeem, for a terrific talk. We have a few minutes here for questions, so maybe we can just try to get through a couple of them quickly. So I'll just go in order here. So are there markers that can predict panic attack?
Yeah, so there has been kind of panic attack. You can see some heart rate changes and heart rate kind of variability changes. And also some changes in galvanic skin response, but they're not unique markers. So one of the things that you could potentially do is, if you know that if you have other contexts to support the patient, someone is not doing physically intensive stuff, they're sitting kind of stationary, and suddenly these markers are, you see a rise in that, can associate it with panic attack. But that's why I also think my kind of thing is that there isn't a unique marker that will always work all of the time, and we need to kind of triage between some of these markers to know when to kind of actuate an intervention if we want to kind of detect panic attack. There are some markers, but they're not uniquely differentiating the panic attack. Yeah.
All right. Another question here. I'm concerned with the thinking of that subjective symptom measurement as a challenge to be overcome. So far, the search for objective biobehavioral markers has largely not panned out very well. How are you thinking about understanding whether treatments are working well for patients without subjective reports?
So I don't think we can eliminate subjective reports. Subjective reports has their problems too, right? Like oftentimes there is kind of recency bias. There is bias of someone who may have recovered from depression and not wanting to like really again go through another episode of relapse, and we see some of those things in subjective report as well. And I completely agree, none of these markers are reliable all of the time, but there is we have seen that there are certain markers that are associated with changes in mental health, like disruption in sleep, someone's social isolation, mobility pattern, and now they're not 100% accurate. So I do think, for example, you can take these digital markers and trigger a self-reported assessment when you have uncertainty. So oftentimes the self-reported assessments are burdensome. Oftentimes the number of assessments you need to do are burdensome. So I think they actually, the best situation right now is how does one trigger the other, and how do we do it in an intelligent way so that we don't also, we get the most reliable information and we don't lose information because people disengage.
Right. Another question here that I think is on a lot of people's minds. What is known about the features of patients who are willing to download and use a passive sensing app and send data back to their healthcare system, healthcare provider or insurer versus those who decline or do not trust this? Relatedly, what kinds of protections on how data are used and stored are most important in your view, and how can these best be communicated to patients to build trust?
So that's a lot. So I think one of the things, actually, there was a recent report from Rock Health and Stanford Medicine that looked at patients' willingness to share digital signal data and marker. And one of the interesting things there, that more and more people are willing to share this data. Of course, I think there's a sharp drop off if someone is over 65, right? And I think that maybe who are digital native, as there's more digital natives, that will probably shift. But one of the interesting things was there was more reluctance in sharing the data with big tech companies compared to health systems and payers, which was actually, I was surprised by, but there was the kind of, so if we can show that it is being used in a way for their benefit, I think there is a real opportunity here. The other is, I think it has to come not just a pair just imposing the solution, and that's why kind of working with the care team and those channels of trust is important. And one of the things why we were doing it within the primary care kind of physician or behavioral health team recommending this solution. And ultimately, I think the privacy aspect is an ethical use of this data is huge. And I think that this is going to evolve over time, and we are going to learn as we deploy. But I think there is, again, a lot of the things that we have seen in this, that the data that needs to be kind of stored or shared with the team is not the level of granularity that you can collect the data, right? So I think a lot of these data, and I've always been kind of a proponent of in the signals we collect, some amount of destructive processing so that we actually are looking at some key indicators and not having to report. And as we in the machine learning front, there's more and more effort happening in embedded machine learning or federated machine learning, where I think over time, as we think about scaling these systems, will ensure some of the privacy aspect. But I think we need to build trust, understand some of the data ethics and fairness issues, as well as really embedding some of these privacy measures on the device for the patient themselves.
All right. Well, Tanzeem, thank you so much for a wonderful talk, and I've seen a lot of compliments coming in through the chat. So
thank you very much.